Hi everyone, this presentation covers Chapter 11 on cohort studies in the third edition of Jacobsen's textbook, Introduction to Health Research Methods, a Practical Guide. In this chapter, you will learn that a cohort study follows participants through time to calculate the rate at which disease occurs and to identify risk factors for the disease. Here is an outline of the chapter. Section 11.1 provides an overview. Section 11.2 covers prospective cohort studies. Section 11.3 covers retrospective cohort studies. Section 11.4 covers longitudinal cohort studies. Section 11.5 goes over data collection. Section 11.6 covers ratios, rates, and risk. Section 11.7 goes over incidence rates. Section 11.8 covers incident rate ratios. Section 11.9 covers attributable risk, and Section 11.10 covers person time analysis. A lot of these concepts were covered in your epidemiology course, so there's a lot of different terminology here used that may be familiar to you. So Section 11.1 provides an overview. So what is a cohort? So a cohort is a group of people that are followed through time together. So any sort of group is a cohort, whether it's your group of students taking a course together or a group of students enrolled in a degree program together, that's considered a cohort. A cohort study is an observational study that follows people forward in time so that the rate of incident or new cases of disease can be measured. And there are three main categories. There's a prospective, a retrospective, and a longitudinal design. Cohort studies should have at least two measurement times, so at least an initial survey at baseline to determine the exposure and disease status, and then follow-up assessments. And these follow-up assessments will determine incident or new cases of the disease. Cohort studies examine incidents of disease, and they can also examine continued exposures as well, and prevalence can also be examined as well, but the main purpose really is to determine these new incident cases. You must be able to demonstrate that the outcome of interest was not present at baseline. So you want to give some sort of baseline assessment of all the health needs in a cohort study, and then each time you follow up, you would ask if someone has developed the diseases that you covered at baseline, and that will tell you if it's a new disease. So figure 11.1 has some key characteristics of cohort studies. So what is the objective here? So the objective of a prospective or a retrospective cohort study is to compare the rates of new or incident disease over time in people with and without a particular well-defined exposure. Now, if you're doing a longitudinal cohort, the objective is to follow this sample and look to see if new diseases are associated with a diversity of exposures. And we'll talk a little bit more in the upcoming slides about the differences between these different types of designs. And so here you can go over this figure on your own. It's very similar to the other chapters on study designs, where it has an example of the objective, primary study question, population, when to use the approach, requirements, first steps, what to watch for, and key statistical measures. So figure 11.2 goes over the framework. So starting off in this first column one here, the first thing you want to think about is, did the individual have the exposure but not the disease at the start of the study? So at baseline, you're looking to see exposure, non-exposure, and then you're moving over to follow up with them to see if during the study period, did the individual develop a new disease? And so from there, the people who are exposed could develop an incident case. But they could also be exposed but have no disease. They could not be exposed, but they could still get the disease, or they could not be exposed and not have the disease. So you have those 4 different options here that work really nicely in a 2x2 contingency table. So what are prospective cohort studies? Section 11.2 covers prospective cohort studies. And this is the standard cohort study that you would think of, that it just follows participants forward in time. It recruits participants because they do or do not have an exposure of interest at baseline, and then they follow them to see if an incident case of disease developed. So this is a study where you have new participants. It's a primary data collection, and it may take a long time to follow people to see if they develop disease. A retrospective cohort study is covered in section 11.3. This is sometimes called a historic cohort study, and here you recruit participants based on the data about their exposure status at some point in the past, and typically also measure the outcome that has already occurred. So really this is like an electronic medical record, perhaps, is what you would use for this, where you can look back and you can see people's exposure in the past, and you can currently see whether or not they've developed the disease or not. And then you line your study up in that framework. Retrospective cohort studies use documented baseline data collected at some point in the past and then follow the cohort to another point in the past or in the present. So figure 11.3 goes over the different times for baseline and follow-up data for cohort studies. So here we have the present in the middle here, then we have the past and the future. So if we're starting off at the present, and we want to look at past exposures, then we will look at a retrospective study. We will use that retrospective study to look at the past exposure. Now the outcome could also be in the past or it could be present. But the one thing that we know that's always going to be in the past is the exposure. Now for a prospective and a longitudinal study, we're starting now. So we are starting here to see if they have the exposure and then following people up in the future. So what is a longitudinal cohort study? So section 11.4 covers these types of studies. A longitudinal cohort study follows a group of individuals who are representative members of a selected population forward in time. They do not recruit participants based on exposure status. They're recruited based on membership in a well-defined source population. So you may have heard of some different famous cohort studies. The Women's Health Initiative is a famous one in the United States where several women are recruited to be in the study and then followed over the time to look at multiple different health outcomes. So they're not looking at just specific exposures and specific outcomes. They're looking at a wide array of different things among a population that is represented. And longitudinal cohort studies can be a fixed population or a dynamic population. A fixed population is when all participants start the study at the same time and no additional participants are added at a later date. Whereas a dynamic population is an open population, and here's where enrollment occurs continuously. So there may be new participants recruited after a study team begins collecting data. So an example of this I can think of is the health and retirement study. They have an open population, they have a dynamic population where they do continue to recruit the sample, particularly because it is a retirement study and the population gets older, and so the sample size gets smaller due to loss to follow-up, so people just decide not to participate for whatever reason. And people also die, and so you need to continue to have people within that sample in order to have precise results. And so figure 11.4 goes over fixed and dynamic populations. And so here if we look at where data collection begins, our figure here, our diamonds are the enrollment, the bluish gray squares are the initial follow-up, and then our circle is the dropouts here. So if we have a fixed population, we have these three scenarios here. So everybody started at baseline. So here we have a fixed population, then we have everybody, the data is collected at the initial follow-up, and then we continue to follow them. Same thing as this next one here. So you have a participant here, and then they follow up, and then they continue to follow up. Now, if these are people and this is our third person, then we have an individual here, they complete the initial follow-up, and then they drop out. And so then that's where, if it was a fixed population, you couldn't make up for that person, and so you would have to, you would just have a smaller sample size. In a dynamic population, if we had this first person that's the same as the fixed population, that person's in the study at baseline, at the initial follow-up, and continuing in the study as normal. Versus the second person is at initial follow-up, and then they drop out. So in an open data collection, you could have recruited people before that initial follow-up in anticipation of people potentially dropping out, and then follow them up. And then your initial follow-ups for each of them will be different, because you wouldn't want to follow them up. Say if this is 3 months, you wouldn't want this to be like a month later when you actually followed them up. So you would adjust their timing. So section 11.5 goes over data collection. All participants complete the same assessments in order to prevent information bias. So you want to have the surveys be the same regardless of when people fill it out, and regardless of whether they're exposed or unexposed. So this occurs when the information bias can occur when exposed participants are more thoroughly examined for the disease than the unexposed. But it's good to have a data management system that's established to link baseline and follow-up data, and also maintaining confidentiality of the information provided by participants. So one way that you can do that is to have a unique identifier for the participants, an ID number, and then you would not put that within the database. You would maybe have that in a secure locked database somewhere else. And so decisions must be made when you have your data collection, how often the follow-up data collection will take place, and how long the study will continue. So particularly if it's just a standard prospective study, you're probably going to need funding to keep that study going. If it's a longitudinal study, it may be a much larger, funded by the government study that may be able to go for a certain period of time, but there's still going to be a wave, let's say. There's still going to be a certain time where you need to look at the data, figure out if it's being done accurately and correctly, and whether or not the study should continue. And so researchers should develop some strategies to minimize the burden on participation while maximizing interest in the participants to continue in the study, because otherwise loss to follow-up will occur, and this is when people drop out, or they may relocate, someone passes away, or they just stop responding for whatever other reason. So section 11.6 goes over ratios, rates, and risks. And so there's lots of different epidemiologic calculations discussed in this chapter. A ratio is really just a comparison of two numbers. It's just a basic division. And so it would be A to B as your ratio, and you would take A divided by B. And so in that equation, your numerator is the top number in the ratio, so the A. The denominator is the bottom number in the ratio, the B. And so typically your reference population is used as a denominator in the rate ratio. So if you're looking at a ratio of how many developed a disease, the number of people that had the disease were the A on the top, and then the reference population would be on the bottom. So proportions are also used. They're really good. I think they're understandable. I think they're really good for health communication. Sometimes we get really bogged down in getting these really fancy statistics. And a ratio really is just, the numerator over the denominator. And it is a proportion that is ranging from 0 to 1. Now, one thing to keep in mind here is it needs to have the same unit. So if you're looking at people, then it would be the people on the top and then the people on the bottom. A percentage really is that number multiplied by 100, and so it's the proportion presented as a unit of per 100. And both of these equal part of a whole. So if you have a ratio of 0.60, your percentage is going to be 60%. Then Jacobsen talks about rate and risk. A rate is a ratio in which the numerator and the denominator have different units. And so typically the denominator is a measure of time. Now I will say you may see things like case fatality rate, but when you do the calculation for that, it's not a measurement of time. And so these are kind of used interchangeably. They can get kind of confused within epidemiology, and the way that things are labeled can get a little bit confusing, but in general, a rate is anything where the denominator is a unit of time, say cases per year. Whereas risk is the probability of cases over a certain period of time. And so, like I said, they're often used interchangeably, particularly in different papers. So, but they're meant to measure risk, and they're meant to measure a similar proportion. So section 11.7 goes over incidence rates. So what is the incidence? Incidence is new cases. This differs from prevalence, which is existing cases. The incident rate is the number of new cases over the total number of people in the population at risk. And so the population at risk consists of people who do not already have the disease being tracked in the cohort study. So that usually would be the number at baseline. However, if someone develops the disease and then you continue following them, then they may be removed from your population. Now, the incidence rate is also sometimes called the absolute risk, and it is termed this way to emphasize that the number is a measurement of the value in a population. But I would say in most of the literature, when you read, they will use it as an incident rate, or if they specify it's an absolute risk, they'll define it. So figure 11.5 goes over incidence and some different calculations here. And so here we have our purple people are those who are already diseased. Our green people are those with new disease. And then I think this is peach, or let's say orange, have no disease. And so here, starting off on our first column on the left, we have 1, 2, 3, 4 with new disease. And this is represented here as the number of new cases, 4. Now our already diseased are these purple, and they're in this X because they don't count as our denominator, because there's no way that they can be a new case of disease because they already have it. And so there's 7 here, so our denominator is 50 minus 7 equals 43. And then it's 4 divided by 43, which gives us 93 per 1,000 people. Now, if we didn't have those 7 people at risk, then here in the middle, we have 50 as our denominator. And then we have 15 green people here. So 15 divided by 50 is 300 per 1,000. Now here we have a whole lot of people with the disease already. So 50 minus 25 equals 25. There's 25 purple people here. There is 1 green person. So 1 divided by 25 is 40 per 1,000. So the incident rate is typically a preferred measurement of incidence. I think it's pretty straightforward for people to understand. Another thing that can be calculated is the cumulative incidence, which is the percentage of people at risk who develop the new disease during a specified period of time. And it's calculated when the time period is relatively short and risk is not negligible. In general, whenever you report incidence, sometimes you can just report it as incidence without using rate and without using cumulative. That's usually how it's reported in the literature because of that difference. And as long as people just define it and what is in their numerator and in their denominator, it makes it so much easier. The attack rate is the cumulative incidence of infection during the course of an epidemic. So section 11.8 goes over incidence rate ratio. So we're not quite done with incidence yet. You can also look at incidence as a ratio, and this is really when you're wanting to compare different populations, and specifically in this case for cohort studies, comparing the exposed to the unexposed. So you're looking at the incidence in those with a particular exposure over those without the exposure. And so it's calculated as A over A plus B divided by C over C plus D. And this is the numbers in a 2x2 contingency table. I'll show you in just a sec here. So here you can see, so if this is our disease status on top, we have cases and controls. And so cases are those with the disease, controls are those without. Exposure status, we have unexposed and exposed here. So A are those with the disease who were exposed, B are those without the disease who were exposed, C are those with the disease who were unexposed, and D were those who do not have the disease and were not exposed. And so the incident rate in the exposed is A over A plus B, so our top row here. And then the incident rate in the unexposed is C over C plus D, and then you divide those two together. And so whenever you have a relative risk, a rate ratio, a hazard ratio, an odds ratio, they all have a reporting with an interpretation that a 1 means no difference in risk. And so incidence rates, if you calculate it out and it's right about 1.0, there's no difference between exposed and unexposed group. If it's greater than 1, then there is a difference and the risk is greater in the exposed compared to the unexposed group, suggesting the exposure is risky. If it's less than 1.0, then you're suggesting that it's lesser in the exposed than the unexposed, and the exposure is protective. So now we also want to always calculate with them a confidence interval. So anytime we calculate a relative risk, we want to calculate the confidence interval to show whether or not it's statistically significant or not between those two groups. And usually a computer program like SAS or Stata will do that for you, although it can be done by hand. And so if the relative risk has a confidence interval that is less than or greater than 1.0. So if it crosses the 1, which is up here, so let's say our rate ratio is 1.2, our lower limit is 0.7 and the upper limit is 2.0, this is not statistically significant. If the rate ratio is 0.5, and both our lower bound and our higher bound are less than 1. So the 95% confidence interval is 0.3 to 0.8, then the exposure is protective. If the relative risk is greater than 1, and we have a confidence interval that is also both the lower bound and the upper bound greater than 1, so here we have the lower bound at 1.4 and the upper bound at 2.8, then we can say the exposure is risky, and both of these are statistically significantly different between the groups. Section 11.5 goes over attributable risk, so another thing that can be calculated in cohort studies. So one thing that can be calculated first really is a rate difference, and this is your excess risk. And this is the absolute difference in the incident rate between the exposure and the exposed and the unexposed. And so it's just a subtraction. And then the attributable risk percentage is a proportion of incident cases among the exposed due to the exposure. And so you're trying to actually do a percentage between the two to show that it's due to the exposure and not some other factor. And then if you want to look population-wise, you can do the population attributable risk. And this is the rate of new disease in a population attributed to some people that have the exposure. And so figure 11.8 goes over the calculations for this here. So absolute risk, as I said, it was just subtraction here. So we have the incidence in the exposed, and then the incidence in the unexposed. And then it gives you an excess incidence due to the exposure. Then if you wanted to do the attributable risk percent, you take that attributable risk and divide it by the incidence in the exposed to get the percentage there. Then figure 11.9 goes over examples of rate ratio calculations. If you're not familiar with these calculations, I would say that I do 2x2 tables a lot, still to this day. After getting my MPH, I did them. After getting my PhD, I did them. It's really good to start learning and understanding calculations for 2x2 tables in your bachelor's degree program so that you can start helping out in labs if that's what you're wanting to do epidemiology-wise. So section 11.10 goes over person time analysis. And person time is when units like person years, person months, or even person days are used to quantify how participants in a study are observed. And so the sum of the person time across all participants is used as a denominator for calculating rates in a study population. I used this recently in a study where we looked at COVID-19 mortality in Michigan among Arab Americans. And it was used because the numbers are fairly small, and compared to the population size, it equalizes the population size between all of them. So if you have 100,000 non-Hispanic white individuals, 2,000 Arab American individuals, by transforming that number into person years, you're able to make a better comparison of the cases when you have different population sizes. So another thing that has to be considered with person time is censoring. And so censoring really is whether or not to include someone who drops out as part of your person time. And so if someone drops out in between a data collection period, you have to decide, do I use their data to the next data collection period, or do I move it back to when the last part was? And so that's just a decision that has to be made when doing that type of analysis. And so figure 11.10 goes over some different scenarios for this. So here we have all of these are people. So we have 10 participants recruited here. So we have 1, 2, 3, 4, 5, 6 at the top, 1, 2, 3, 4 at the bottom. So those are our 10 people. So at 1 year, we see how many people are still there. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. They're all still there. Okay, so our cumulative incidence is 0 over 10 person years. Now, at year 2, we see that one person's gone, and then we have one person who was diagnosed with the disease. So we have removed this person because they're not in the data collection period anymore. So you have 1 over 19 person years. Now the reason why it's not 10 is because you have 10 years for all these 10 people for the first year, and then you have 9 additional years observed because you only have 1 year from this person, but you have 2 years from all these people. Then at the third year, you have 26 person years. So you have 10 years from the first year, then you have 9 years from the second year, and then you don't have this person anymore, you don't have this person anymore, and you don't have this person anymore. So it's 1 over 26. And then at 4 years, you have another diagnosis. So here we keep this one diagnosis from here and the other diagnosis from there, and then we attribute the additional years for these people above and for this person right here as well. So I hope that's helpful for explaining person year analysis. And that is it on Chapter 11 on cohort studies. Thank you for listening.